right. Well, welcome everyone to our winter 2022 meeting. Although we haven't met for several months, I can assure you that our staff has been hard at work, and you will see the benefits of that work over the course of this meeting. I've had to memorize the plan of attack because it's a complicated one. And I don't like to memorize plans of attack because it takes all the spontaneity away. But let me give you a kind of a very quick lay of the land. Our plan is to, while we're in public session, to take 2 votes on our missing minutes of September 15th and November 8th. As you probably remember, because we are in Zoom land, we will have to do this by a roll call vote, which Colleen will take us through. After we have completed that process, we will take a vote to go into executive session to focus on confidential material that we've received from CHIA and from other sources, which we use to determine whether any provider group or health plan requires a performance improvement plan. Assuming that we will vote in favor of that executive session, we will then go into executive session and review that material and decide what we want to, how we want to move forward. After we get that completed, we will come back into public session around 1 o'clock to decide officially how we proceed with the performance improvement activity, and to review a very detailed report that the staff has done in terms of the potential expansion of Massachusetts General Brigham in terms of expanding its hospital capacity and its ambulatory capacity in several of our suburbs. So everyone got that? All right. So let us begin by deciding whether to accept the minutes, and I will now turn the microphone over to our esteemed leader of votes, Colleen Estemier. Colleen?
Thank you so much, Mr. Chairman. We'll start with any amendments to the minutes from September 15th, 2021. Seeing no amendments, I'll ask for a motion to vote.
So moved.
And a second, please. Thank you. I will start with a roll call vote of each commissioner present, starting with you, Mr. Chairman.
Approve.
Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Foley.
Aye.
Commissioner Haupt.
Aye.
Commissioner Kreider.
Aye.
Commissioner Master Giovanni.
Aye.
Secretary Sutters.
I'm abstaining because I missed most of the meeting.
Thank you. And Commissioner Roeder.
Aye.
Thank you so much. Moving quickly, asking for any amendments to the minutes from November 8th, 2021. Seeing none, we'll ask for a motion to vote on the minutes.
Motion to
moved.
approve.
And a
Okay.
second, please.
Second.
Thank you. Start with you, Mr. Chairman.
Approve.
Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Foley.
Aye.
Commissioner Haupt.
Aye.
Commissioner Kreider.
Aye.
Commissioner Master Giovanni.
Aye.
Secretary Sutters.
Aye.
Commissioner Roeder.
I'll abstain.
Thank you. Finally, we'll be asking for a vote to enter into executive session. Do I have a motion
So moved.
and a second?
Second.
Roll call vote, starting with you, Mr. Chairman.
Approve.
Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Foley.
Aye.
Commissioner Haupt.
Aye.
Commissioner Kreider.
Yep.
Commissioner Master Giovanni.
Aye.
Madam Secretary
Aye.
and Commissioner Roeder.
Aye.
Thank you. And with that, we will move.
Good afternoon. We're live.
All right, welcome back. So the full commission met in executive session and unanimously recommended that we seek a definitive improvement plan from the Massachusetts General Brigham entity based on our analysis of their spending in the period 2016, 2017, and 2017, 2018. I want to emphasize to all of you, this is an extremely important aspect of the activities of the Health Policy Commission. And we have been very judicious about its use. In fact, this is the first time that the Health Policy Commission has made such a recommendation to an entity. It's the mechanism that the Health Policy Commission uses to make sure that where possible, our overall spending for the state is consistent with the spending benchmark indicated in our legislative authority. We have reviewed all the data that was sent to us by CHIA. We've reviewed other published information. We've met, the staff has met with the MGB people several times, and I and several of our commissioners have met with them. And this is a complicated process, and I'm going to turn the program over to our executive director to go through in detail what the process is and how we reach this decision. And you will see we will do it in an orderly way and make sure that we have reviewed all the relevant material. So let me now turn the program back to our executive director, David Sells.
Thank you, Chair Altman, and good afternoon. I will provide just a brief overview of the performance improvement plan process. As Chair Altman said, the decision to require a performance improvement plan and a summary of and standard of the HPC's analysis of the factors of review. As Chair Altman just said, the process for reviewing the spending performance of individual healthcare providers and health plans and determining whether a performance improvement plan is warranted or not is the primary accountability tool for ensuring commitment to the state's healthcare cost growth benchmark. The HPC has conducted this cycle of review in the context of statewide over benchmark performance in the last 2 years of data. And a performance improvement plan will give MGB the opportunity to directly address its spending trends in a publicly accountable way, and in so doing, help advance affordability for the residents of the Commonwealth. On the next slide, you can see that this is a multi-step process every year, and we have conducted this review cycle every year for the past 6 years. So in step one, the Health Policy Commission, along with the Joint Committee of Healthcare Financing, engaged in a process to set the annual healthcare cost growth benchmark. Every year, CHIA then collects data from health plans on unadjusted and health status adjusted total medical expenses for their members, in this case, attributed members of the primary care group of that entity. In this case, Partners Community Physicians Organization is the largest physician organization within MGB. CHIA in step 3 analyzes those data and confidentially refers to the HPC payers and primary care providers whose increase in health status adjusted TME is above a certain threshold. In step 4, having received that confidential list, the HPC conducts a confidential but extremely robust review of each referred provider or health plan's performance across multiple factors. And I'll speak a little bit more to that shortly. In step 5, where we are today, after reviewing all of the information, including confidential information and engagement with the referred entities, the HPC board votes to require a PIP if it identifies significant concerns and finds that the PIP could result in meaningful cost-saving reforms. And step 6 will be the implementation of that performance improvement plan. On the next slide, stepping back to step 4 to talk about our internal review process. This is a comprehensive review process that has multiple steps, including an initial review of the referred entities across a whole range of performance metrics as laid out in our statute and regulation, including both health status and unadjusted TME, growth level and comparison to peers, their relative price and price growth, and the long-term spending impact performance of the entity. We engage with follow-up with commissioners throughout this process and engage directly with the entities under review to solicit their own information and data around explanations to drive their spending growth, efforts to mitigate that spending growth through innovations, and other factors that may be outside of the entity's control and may be relevant to the board's consideration and deliberation of whether a performance improvement plan is warranted. On the next slide, you can see here that even as the initial referral factor to the HPC from CHIA is based on health status adjusted TME or total medical expense growth, the statute and the regulation require that the board consider a number of other factors in deciding whether a PIP is warranted. These factors include spending, baseline spending and spending trends over time, pricing patterns over time, and again, ongoing strategies or investments that may improve the efficiency and reduce spending growth. On the next slide, you can see that this has been our 6th year of going through this rigorous review process. Specifically, I would note that this 6 years provides some benefits to our review process, specifically where Chapter 224 requires that the HPC consider performance trends over time. And in this case, the HPC examined MGB's performance over multiple years. And this allows the HPC to base a decision to require a PIP on those longer trends as opposed to a single year trend. Additionally, with additional years of data, the HPC can better review and differentiate between one-time cost drivers and efforts that are persistently concerning. This final next slide here highlights the timeline for this review cycle, which encompassed ultimately 2 years of lists referred entities from CHIA. We paused the initial referral list in March 2020 and re-began the review process in May 2021. This has been a approximately 9-month review process with multiple stages of back and forth with both the board and the entities under review. And I would note that this 9-month timeline is pretty typical for a review cycle. And so would note that while there is another item on our agenda related to MGB today, this was a separate review process with a separate set of factors on its own timeline leading to today. So finally, on this next slide, the board has, as Chair Altman said, voted to require a performance improvement plan from Mass General Brigham based on the referral of their Partners Community Physicians Organization, their largest physician group, and the TME of those patients, as well as the multi-year trends and multifactorial review undergone by the HPC. We note that the spending performance raises significant concerns and has likely already impacted the state's ability to meet the cost growth benchmark. And unless addressed, will continue to impact, likely continue impact the benchmark. We did meet with the entities, and information provided did not allay the primary concerns identified by the HPC. And so as a result, the HPC has determined that a performance improvement plan could result in meaningful cost savings reforms for the future. To close out this summary, I do want to provide a further detail of what some of those primary concerns were and around spending performance that contributed to the board's decision. So I will turn it over to Kara Vidal for just a few data slides here.
Thank you, David. The HPC uses total medical expenses, or TME, as its primary metric for evaluating spending performance. TME is a measure of all medical spending, so inpatient, outpatient, professional, pharmacy, et cetera, for a group of patients, reflecting, in this case, primary care providers' responsibility for managing overall spend for their patients. MGB's TME levels are consistently above payer network averages, which are shown here in dark blue, and are consistently among the highest in the Commonwealth. This is true across payers over time and both an unadjusted and health status adjusted basis. And as David mentioned, the HPC does look at both unadjusted and health status adjusted TME as part of this process. Unadjusted TME reflects actual dollar spending, whereas health status adjusted TME is intended to reflect the health status of the patient population and is calculated by dividing the unadjusted TME by a risk score. However, risk scores also affect payment levels. And we have seen across the market, not just at MGB, a growth in risk scores beyond what we would expect based solely on changes in the health status of Massachusetts residents. Therefore, when evaluating trends over time, we must consider unadjusted TME because the health status adjusted trends typically deflate the spending. As part of our discussions in the PIPS process, MGB confirmed that the health status of its primary care population was not meaningfully worsening over this time period. On the next slide, you'll see that in addition to having high spending levels, we found that MGB's TME has grown apace or even faster than the network average growth rate across the big three commercial payers. Even in alternative payment contracts, we found that MGB spending performance exceeded the benchmark across payers and years. And on the next slide, you'll see that MGB's high spending levels, high spending growth and size combined to generate a significant financial impact over the last 6 years. MGB has generated $293 million of above benchmark spending. That is dollars that would not have been spent if their high growth contracts had instead grown at rates below the benchmark. MGB spending impact is by far the highest for all providers in the Commonwealth over the last 6 years and is more than double that of the next highest provider as seen on this slide. These figures are based on unadjusted TME, which is significant for two reasons. The first is that the state's healthcare cost growth benchmark is also an unadjusted figure, and measuring entities' direct impacts on the benchmark is necessary for accountability. The second is that, as previously noted, MGB stated during this process that the health status of its primary care population was not meaningfully worsening during this time, which, as a reminder, is a time period that predates COVID, and that its rising risk scores were the result of changes in its clinical risk coding activity. Therefore, given that MGB's primary care population was clinically comparable on a year-over-year basis, unadjusted TME is the most appropriate measure. Finally, I want to emphasize that, as demonstrated by this slide, the board's concerns are not based on MGB spending performance in a single contract or in a single year, but rather with its pattern of persistently high spending growth across time and payers and the resulting financial impact on the Commonwealth. In addition to evaluating MGB spending growth, on the next slide, you'll see that the HBC also assessed the additional factors laid out in the PIPS regulation. Taken together, these factors did not mitigate the HBC's concerns and in some cases exacerbated. I won't review each factor individually. I'll just highlight a few select findings on this slide and the next. So on factor B, pricing patterns and trends over time, we note that MGB's hospital and physician prices are higher than nearly every other provider in the Commonwealth, and price is, of course, a direct input to overall spending. On factor C, utilization patterns and trends over time, we found that for the clinical categories driving MGB spending growth, price and mix had a larger impact on growth than utilization. And then finally, on factor G on the following slide, which is ongoing strategies to reduce spending growth, MGB described its strategies going forward as a continuation of its current efforts, including clinical and care management programs, shifting care to lower cost settings, and taking on more risk. As evidenced by its spending patterns over the last 6 years, these strategies have not been sufficient to keep MGB's spending growth under the benchmark to date. And further, MGB's preliminary 2018 to 2019 TME data shows similar spending trends. I'll pause here in case David or commissioners want to offer any additional insights or commentary.
Thank you, Kara. Are there any questions or comments about either David's comments or Kara's from our commissioners? Okay. So, David, let us proceed.
Thank you, Mr. Chairman. So we'll take a minute to just discuss some next steps. And Kara, if you want to highlight where we go next.
Sure. So looking to the next steps in the process, MGB will have 45 days after receipt of its PIP notice to either file a PIP proposal, request a waiver, or request an extension to the filing deadline. Waiver requests and extension requests of more than 45 days require a vote of the board for approval. The board will also have to vote on whether to approve the proposed PIP, which must be filed using the standard forms and instructions on the HPC's website, and which will be posted to the website once it is approved. Per statute, the proposed plan must be developed by MGB, but they are encouraged to partner with HPC in that process. On the next slide, you'll see the standards that the board will use for determining whether to approve a proposed PIP. So the board shall approve a proposed PIP if it determines first that it is reasonably likely to address the underlying causes of growth, and second, that MGB will be capable of successfully implementing the plan. The board will also consider whether there's a reasonable rationale and evidence base for the proposal, the scope and likelihood of the proposed estimated savings, sustainability, risk of negative unintended consequences, and other factors that it determines to be in the public interest. On the last slide, you'll see a timeline here. We expect to receive either a PIP proposal, a waiver request, or an extension request by mid-March, and we'll have a process update at that time.
Okay. So, all right, again, are there any comments or questions about the process from any of my fellow commissioners? Okay, David.
Well, thank you, Mr. Chairman. That was the conclusion of our slides on the PIPS review process. So, and the decision of the board. And unless there is further questions or commentary, we can move on to our next agenda item.
Very good. Again, I want to thank Kara and the staff for an incredible amount of work that went into this process and the detail in which the staff engaged. I've been involved in activities in healthcare for many years, and I would put it at the highest level. So thank you, Kara and David and the whole staff. So let us now move on to another very important aspect of our work, which is the review of the Massachusetts General Brigham proposals to substantially expand their capacities at the inpatient level at the Massachusetts General Hospital and at the Faulkner, and in their proposal to expand their outpatient in 3 areas of the Commonwealth. So with that, I'm going to turn the program back to David to take us through this process.
Great. Thank you, Mr. Chairman. So we will now turn to a proposed or draft comment for the board's consideration to be filed into the determination of need review process administered by the Department of Public Health. I will note at the top that this is a separate review process from the topic that we just talked about, and subject to its own unique timelines and process. And before we get into the details, would like to publicly acknowledge the Department of Public Health and their work in reviewing these applications, their work in being a safeguard and administering this program, and their general partnership and professionalism throughout this entire process, and acknowledge their incredible commitment. So thank you to our colleagues at the Department of Public Health. And we hope that if approved by this board, that this comment will aid in the review. So with that as a small disclaimer and an opening remark, we will now walk through the process and the role that the HPC plays here, and we'll summarize at a high level our findings from this comment, and then we'll turn to the board for consideration of approval to submit this comment into the determination of need program. So with that, I will turn it over to the director of our market oversight team, Kate Mills.
Great. Thank you very much, David, and good afternoon, commissioners. So just as David teed up, I wanted to start with a little bit of a refresher, just to reorient people to what this process is. So as I'm sure the commissioners recall, having seen this slide before, providers are required to submit an application to the state's determination of need program within the Department of Public Health before they can make specific types of changes to their operations. So these include things like major capital expenditures, substantial changes in services, adding specific types of equipment, and changes to licensure. And a lot of those don't actually require a material change notice with the HPC. So material change notices are kind of their own separate process where the overlap is really limited primarily to where we see hospital changes of ownership and a few types of joint ventures. But that does not mean that the HPC doesn't have a really important role in this determination of need process. So under Chapter 224, the same legislation that created the HPC, we were given the explicit authority to provide comment into the determination of need program on any pending application. And the determination of need program regulations further provide that the HPC is what's called a party of record. So we receive all filings in connection with the determination of need applications, and we have the ability to provide comments, including comments on any independent cost analyses that may be conducted in connection with an application. The factors that the determination of need program uses to determine whether a determination of need need application will be approved are laid out in their regulation, and we've really just highlighted two here that are have a particular nexus with the work of the HPC in developing policies to reduce cost growth while improving quality, reducing healthcare disparities, and developing a value-based market. So the first one here, drawn from factor 1F, requires that an applicant demonstrate that a proposed project will compete on the basis of price, TME, provider costs, and other recognized measures of healthcare spending. And the second one here, which is drawn from factor 2A, requires that the applicant demonstrate that a proposed project will meaningfully contribute to the Commonwealth's goals for cost containment, as well as improved public health outcomes and delivery system transformation. And for this last factor, the Department of Public Health has discretion to require what's called an independent cost analysis, which is paid for by the applicant to demonstrate that a project is consistent with the Commonwealth's cost containment goals. On the next slide, you'll see a little bit more about the particular applications that are at issue today. So today we're talking about 3 determination of need filings by Mass General Brigham, formerly Partners Healthcare, proposing a $2.3 billion expenditure to fund expansion, renovation, and improvement at Mass General Hospital, expansion, renovation, and improvement at Brigham and Women's Faulkner Hospital, and the creation of 3 new ambulatory sites in Massachusetts. And I'll note that there is an additional site that is being proposed in Salem, New Hampshire, that is not under review here in Massachusetts. And the next few slides walk through those proposals in a little bit more depth, so I won't belabor them here. But to give you a sense of where we are in the process, the Department of Public Health has heard and received extensive public comment at this point, and hearing testimony. They received over 1,000 written comments. A number of 10 taxpayer groups have been formed. So these are groups of any 10 taxpayers that can register with the Department of Public Health relative to a specific determination of need application. And that essentially makes them a party of record, like the HPC. And the determination of need program also required in this case for all 3 of these applications that an independent cost analysis be conducted. And so a third-party contractor was hired to conduct those, and those analyses were released on December 28th, triggering a 30-day period during which the HPC and other parties of record can comment. So that 30-day period expires this Thursday. During the pendency of that ICA review, though, the HPC also began its own review of the likely impacts of these proposed expansions, really built off of the types of analyses, data sources, and expert resources that we use across many different parts of our work, including cost and market impact reviews. But I will note that there is a little bit of a limitation in the types of work that we can do here, in that we don't have the ability to solicit confidential information through this process. So we've built all of our work that we'll be going over in the upcoming slides off of information that is publicly available. On the next slide, you see just a quick reminder of what is in these DON applications, and I'm not going to belabor these, but as you see here, the DON applications contemplate major expansions of both inpatient and outpatient care at both MGH with a price tag of $1.88 billion, and at Faulkner with a price tag of $150 million. In total, those proposed expansions would increase inpatient beds at Mass General by 16.6 to 18.9%, depending on kind of how you count some of those beds, and the beds at Faulkner by 45.6%. So very large expansions. The next slide just quickly summarizes the 3 new ambulatory sites being proposed in Westboro, Westwood, and Woburn. And as noted, a similar site is being proposed in Salem, New Hampshire. In total, Mass General Brigham proposes to spend $223.7 million on the Massachusetts sites, or $400 million in total if you take into account the Salem, New Hampshire site. And these are intended to be quite large facilities, with an ambulatory surgery center at each, as well as extensive imaging and a range of primary care and specialty physician services, as well as integrated behavioral health. The next slide summarizes the rationale that Mass General Brigham has provided for these expansions. So in their determination of need filings, Mass General Brigham emphasizes that these projects are all part of a system-wide strategy focused on providing services that meet the needs of their patients and which will lower costs, reduce TME, and healthcare spending. And in particular for the Faulkner and ambulatory sites, the premise is really largely around shifting care to lower cost settings. And MGB states in its applications that the ambulatory sites will be priced 25% lower than its community hospitals. But I'll note that these goals don't appear to be entirely internally consistent. So if MGB does seek to reduce spending by shifting care out of its hospitals and into the ambulatory sites, or out of its AMCs and into Faulkner, it would really be needing to reduce hospital outpatient services to account for the diversion of care out of those higher priced settings. But instead, we see that Mass General Brigham is simultaneously proposing to substantially expand services, including at one of their flagship AMCs, Mass General. And then other sources of information summarized in this orange box at the bottom also paint a bit of a different picture of Mass General Brigham's goals. So in particular, there was some new information that was disclosed in connection with this year's cost trends hearings that was drawn from Mass General Brigham's internal planning documents. And those documents showed that the ambulatory expansion proposed here, these 3 sites, are actually part of a much larger multi-year ambulatory expansion plan. And I'll note that we don't have further detail. We just know that there's a larger plan, but we don't know exactly what else that may entail. And here you see some summary information from those disclosures. This larger multi-year ambulatory expansion plan is expected to contribute direct margins, and that's a quote from the materials, direct margins to the system of $385 million per year. And that reflects both ambulatory volume as well as new hospital volume that Mass General Brigham expects would come from these ambulatory sites. And Mass General Brigham in their internal documents project that this new hospital margin will outweigh any losses from shifting care to lower price sites. And they're also projecting very large market share increases, as you see summarized here. And I'll note that all of this information is actually also consistent with other information that we've seen in other contexts. So for example, Mass General Brigham did a presentation to JP Morgan last year that highlighted that a goal of its ambulatory expansions in those 3 Massachusetts towns and in Salem, New Hampshire, was really about increasing commercial referral volume and network lives. So that gives you a little bit of an orientation to what the process has been to date, what is being proposed. This next slide gives the very high level of the HPC's takeaways. And we'll of course walk through these in far more depth, but I do want to pause a little bit on this slide and go through it. So first, the HPC found that these proposals are likely to drive substantial new patient volume and revenue to the higher cost Mass General Brigham system, particularly commercially insured volume that will reduce and increase healthcare spending, increase commercial insurance premiums, and will negatively impact healthcare market functioning, including access and equity. We were able to model only a subset of the potential spending drivers, and we focused on the commercial insurance market because that is the segment of the market that is likely to most directly flow back to residents and businesses in the form of higher insurance premiums. But just for that subset of the aspects of these that we were able to model, we found that they are likely to increase yearly commercial health insurance spending by $46 million to $90.1 million in total, breaking down, as you see here, $9.3 million to $27.9 million for the ambulatory expansion, 6.4 to 7.9 for Faulkner, and 30.3 to 54.4 due to the Mass General Hospital expansion. But this story isn't really exclusively about the spending impacts either. We also expect that these projects will shift substantial commercial revenue out of other provider systems and into the MGB system. So we are projecting that other providers in the Commonwealth would have a loss of commercial revenue in the range of 152.9 to 261.1 million, as you see here. These providers generally have fewer financial resources than Mass General Brigham. They have lower average prices, and they generally serve larger proportions of mass health patients and communities with higher indicia of social need. So those will all have potential impacts on healthcare access and equity. Given all of these findings, the HPC's high-level takeaway is that these projects are not consistent with the Commonwealth's goals for cost containment. And the remainder of these slides detail a little bit more on that. So first, I want to just note that there was an independent cost analysis, as I said, that was conducted on each of these three applications. But our conclusions do differ from that independent cost analysis pretty substantially. Those independent cost analyses did conclude that the projects were consistent with the Commonwealth's cost containment goals, but they left out a lot. They left out a lot of the drivers of spending that we're going to be going through. They minimize some of the significant cost impacts that they do find. They didn't incorporate certain publicly available information about the plans. And last but not least, they are certainly miss a lot of key context about the way that the provider market is currently structured and functioning in Massachusetts. And some of that key context is really summarized on this slide. So first, it's important to remember that Mass General Brigham is already the largest provider system in the state. It's also already been expanding more than other systems in recent years. So Mass General Brigham already has the highest share of revenue and generally the highest share by volume for inpatient, outpatient, and physician services. It has significant existing market share in all of the areas where it is proposing to expand. It also has prices, as HPC and others have reported for many years, prices that are already higher, often significantly, than nearly all other providers. And this is really one of the core reasons why there are such significant spending impacts, because any care shifting from other providers to the MGB system will generally be cost increasing because of the pricing differential between other providers and Mass General Brigham. Next, as you see here, Mass General Brigham is a high quality provider system, but a lot of the services that they are looking to expand really are services that can be provided readily by other high quality Massachusetts providers. Next, as we just went over in the previous presentation, Mass General Brigham's primary care patients have substantially higher health status adjusted spending than the patients of other systems, and that spending is also growing faster than average. Next, it's important to note that the Mass General Brigham providers generally serve higher proportions of commercially insured patients and patients from wealthier communities, as well as fewer mass health patients as compared to other providers. So Mass General Brigham hospitals have the highest percentage of commercial volume among Massachusetts hospitals for inpatient and outpatient care, and the lowest percentage of Medicaid volume. Mass General Brigham primary care providers also serve patients where, and we have a lot of detail on all of this in the comment, who generally come from higher income communities and have fewer markers of social need as compared to the patients of other systems. And finally, Mass General Brigham has substantially more financial resources than other Massachusetts provider systems. Its net assets of $10.6 billion are more than the next 4 systems combined. So with that context, I'm going to turn it over next to my colleague, Sasha Hayes-Rusnov, to discuss our findings on the spending implications.
Thank you, Kate, and good afternoon, commissioners. So as Kate's described, we quantified potential impacts on spending for a set of spending drivers that would be associated with the projects, with a focus on spending impacts on the commercial market. If we want to move on to the next slide, yes. We're starting with the spending impacts on the ambulatory expansions. You can see here 4 key mechanisms that we expect would impact spending, and I'll walk through these in order. The comment, as you know, commissioners, contains a lot of detail on our methodologies and findings. I'm going to be providing a very high-level summary, but of course, happy to answer more specific questions. If you have them, please do raise your hands. So the first dynamic here on the next slide is the addition of MGB primary care capacity at the ambulatory sites. As MGB recruits new primary care physicians from existing area practices, or as patients switch to new MGB primary care providers from other practices, we would expect a spending impact for patients as their spending changes to look more like the typical spending for MGB primary care patients. As you saw earlier in the TME summary slides, patients of MGB PCPs have higher TME than patients of other physician groups, reflecting differences in price, utilization, provider mix, and service mix. Comparing MGB spending to weighted average spending for other groups serving the proposed ambulatory service areas, we find MGB spending is 11 to 12% higher after adjusting for patient health status. And depending on the number of new PCPs that MGB staffs at the sites, that 11 to 12% differential translates into a yearly commercial spending increase of $9.5 million to $15.4 million each year. So that is the first dynamic. Second dynamic is the potential for increased spending as MGB hospitals draw increased inpatient and outpatient volume from the ambulatory service areas. We expect that the proposed ambulatory sites would drive additional patient volume to MGB hospitals, especially for inpatient care, as well as for advanced outpatient care not offered at the ambulatory sites. We developed an econometric model based on historic Massachusetts data that confirmed a statistically significant relationship between both primary care and specialist physician market shares and the use of affiliated hospitals for inpatient care. And MGB's planning materials for its larger multi-year ambulatory expansion, as Kate described, estimate an increase in inpatient market shares of 1 to 2% for secondary admissions, 3 to 4% for tertiary admissions in Eastern Massachusetts. As Kate described, we don't know for sure what proportion of the expected increase would be driven by the 3 sites currently under review, but if MGB were to achieve half of the projected increase in inpatient market share, that would translate to approximately $4.5 million to $17.9 million in yearly additional commercial spending on inpatient care, based on our models of where those patients would likely be drawn from and the differences in price between MGB hospitals and other hospitals. And of course, if the 3 sites were to represent, say, a quarter of the overall multi-year plan, the spending impact would be roughly half of that, $2.2 to $8.9 million. On the next slide, we have patients actually using the new ambulatory sites. As patients fill the proposed capacity at the ambulatory sites, the impact on spending would really depend on where those patients would otherwise have gone for care. MGB's application suggests that virtually all of the proposed capacity at the ambulatory sites would be filled by patients who would have received care just at an MGB hospital. However, based on the number of other providers serving substantial shares of patients in the proposed service areas, as well as our review of current site of care choices for MGB patients, we consider it more likely that the new capacity at the ambulatory sites would be filled by shifts from providers currently serving the relevant service areas, both from MGB as well as from other providers. And our comment shows a few different scenarios that we modeled for what the mix of volume filling that capacity could look like. On the next slide, we have an example of our preferred model with care drawn from all providers serving the ambulatory service areas current to proportional shares. Taking both facility and professional revenue for the relevant services, we calculated a weighted average price for all other providers in the areas, which you see in the blue bar here. We also estimated a price for the new MGB sites in yellow here, taking MGB's statements that they would be 25% cheaper than MGB's community hospitals. And you can see this is an example for MRI services specifically, that the prices for the new sites would be lower than on average than the average of other area providers, but still higher than some providers, particularly smaller clinic licensed sites. Based on the price differentials between current providers and the new sites and the volume of services that would fill the capacity, we estimate a small commercial savings for ambulatory surgery, CT, and MR scans delivered at the new sites. We also expect that to the extent that care comes from MGB hospitals, MGB would be likely to backfill that newly available capacity, which on balance would be spending increasing. Taking both the shift of patients to the ambulatory sites as well as that backfill effect into account, we estimate a commercial savings of $3.4 million for CT, MR, and ambulatory surgery services based on current prices. And we would expect additional impacts from specialist physician visits at the proposed sites that we weren't able to model. And finally, on the next slide, as patients shift to the new ambulatory sites, MGB would gain commercial market share. And as you know, commissioners, increased commercial market share, particularly in concentrated markets, is generally associated with greater leverage for a provider organization to negotiate higher prices with commercial payers. While we weren't able to model expected changes in market leverage for the ambulatory sites overall, the dynamic would tend to reduce the amount of savings associated with shifts in care to the ambulatory sites as MGB prices rose, and further increase spending for MGB hospitals and the additional volume that they would draw from the ambulatory service areas. On the next slide, you can see a breakdown of the top line numbers for all the effects that I just described for the ambulatory sites. We estimate total commercial spending increases of $9.3 million to $27.9 million each year for these effects. I'll note these estimates are conservative. They do not include other dynamics that would be likely to increase spending, like differences in prices for physician visits, as I just mentioned, as well as additional outpatient volume going to MGB hospitals. Line 2 here models only inpatient volume, and potentially increased MGB prices as the market shares grow, as noted in line 4 here. You can also see on the right side of this table that the spending impacts would be based on much larger shifts in revenue away from other providers and to MGB, which would likely have further implications for market functioning, including access and equity impacts that we'll cover later. So those are the spending drivers and implications for the ambulatory sites. On the next slide, and then the next, with regard to MGH and Faulkner, you can see here the spending mechanisms for the hospital projects that would tend to impact spending. Next slide, the first of these is that spending is likely to increase as MGH and Faulkner fill proposed new inpatient capacity. As described on prior slides, the MGH project would add net new capacity of between 124 to 168 beds, taking into account new bed construction, as well as capacity that would become available as double-bedded rooms are decompressed and beds out of service are potentially brought back into operation. The Faulkner project would add 78 new beds. And as mentioned previously, that results in a total medical surgical bed capacity increase of 16.6% to 18.9% at MGH and 45.6% at Faulkner. We use an econometric model to predict where new volume would fill those beds would likely come from, and calculated the spending impact based on the prices of MGB and Faulkner compared to other hospitals that they would draw volume from. We also modeled scenarios with a range of assumptions regarding future payer mix, length of stay, and share of out-of-state volume filling those capacity. Including both facility and professional revenue, the MGH project would increase annual commercial spending on inpatient care between $23.7 to $40.6 million, Faulkner would be a $2.9 million to $3.8 million increase. For outpatient capacity on the next slide, we focused on the addition of advanced imaging, that is CT and MR units at MGH and Faulkner. Using a method similar to the one that I described for the ambulatory sites, we compared MGH and Faulkner prices to those of other providers of those services that operate within the hospital's outpatient service areas. Because of MGH's high commercial prices for outpatient care relative to others, outpatient care filling new capacity at MGH is likely to increase annual commercial spending by approximately $500,000 as patients fill new CT and MR capacity. Because Faulkner competes for outpatient care with some higher priced hospitals, including AMCs, commercial spending may decrease for some services. We predict nearly $100,000 worth of savings as commercial patients fill Faulkner's new MRI unit. That may not necessarily be true for all of Faulkner's outpatient services, but volume in others is likely to be relatively low. We didn't quantify spending impacts for the expansion of other outpatient service lines at MGH, including PET-CT, cardiovascular, and oncology visits due to data limitations. But given MGB's higher relative prices, those would also likely be cost increasing. And finally, the third dynamic here on the next slide, as discussed previously, new commercial volume for MGH and Faulkner would tend to translate into an increase in market leverage and allow MGB to negotiate higher future rate increases. That's particularly true for inpatient services, where MGB already has the highest market share and the market is highly concentrated in these service areas. The new beds would represent a 7.1 to 7.9 increase in total bed capacity across all of MGB's hospitals. And we expect MGB's inpatient commercial market share in Eastern Massachusetts would increase by 2.7 to 3.8% as those beds are filled. Using a regression model similar to that we've used in prior provider price variation analyses, we estimated what the impact might be on inpatient prices as a result of increases in beds and discharges in these projects. The model suggests that the expansions would result in system-wide inpatient prices at MGB that are between 0.9% to 1.7% higher than current pricing. That would translate to an annual increase in commercial spending of $9.7 million to $17.3 million in total across both projects. These estimates don't incorporate potential changes in leverage that would be associated with the expansion of hospital outpatient services being added. So on the next slide, you can see again the overview of the impacts that I've just described, as well as the associated revenue shifts on the right-hand side. And again, I'll note that these spending impacts we believe are conservative and don't take into account other dynamics such as impacts of non-imaging outpatient service lines at the hospitals. And then on the next slide, the development of the three projects together, importantly, may have greater impacts than any one of them separately. First, as Kate previously described, the ambulatory and the hospital projects have been described as part of a system-wide strategy, but shifting outpatient care out of hospitals and into ambulatory sites can result in savings, but the amount of savings depends on which hospitals would otherwise have provided the care and whether hospitals subsequently backfill newly available capacity. MGB proposes to substantially expand hospital outpatient and inpatient services at the same time as expanding its ambulatory capacity, and the projects together therefore seem likely to increase the volume of care both at MGB's relatively high-priced hospitals and at the new ambulatory sites. Second, if the ambulatory sites increase utilization of MGB hospitals by residents of the ambulatory service areas, more of the care filling the new capacity at MGH and Faulkner may be diverted from lower-priced hospitals outside of the Boston metro area rather than where they normally would come from, which would result in somewhat higher inpatient spending impacts than we've shown here. And finally, the potential for the projects to destabilize lower price providers is greater if all three projects proceed, given that the large combined revenue losses if MGB expands capacity across multiple projects at the same time. That could drive more volume into higher price providers, amplifying all of the spending impacts that we've discussed, as well as potentially impacting market function in terms of access to care and health equity. I will pause here before we move on to that discussion, though.
A lot of information, important stuff. Well, let me ask my fellow commissioners whether there are any questions or comments. So far, this was a very detailed discussion. More to follow, though. Don?
Sasha and Kate, first, thank you very much. With respect to projects not yet on the screen, you said there's indication of expansion plans beyond the 2.3 or 2.4 billion we're looking at. I believe at JP Morgan, I've heard that Newton Wellesley Hospital is planning something like 1.2 billion construction or replacement. Have you got any other figures or any other specifications on what's coming downstream?
I would say that the information available to us is limited. Obviously, there have been some recent press stories regarding MGB's capital expenditure plans in the coming years, but as to what was contemplated in the planning documents that we have more specific information from the cost trends hearings, we don't know exactly what the scope of that multi-year ambulatory project looks like.
Thank you.
Any other questions or comments? So Sasha or Kate, you want to continue your presentation?
I'm going to pass it back to Kate to address some points regarding market function and healthcare access and equity.
Great, thank you, Sasha. So the HBC's cost containment goals, as you all know, are not simply about reducing healthcare costs, but also about restraining the growth in healthcare costs while also improving access, equity, and market functioning. So in addition to assessing impacts on spending, we also reviewed these projects for potential impacts to market functioning, including healthcare access and equity. And as you see in the title here, we do find that the projects raise significant concerns about those impacts. Focusing on the first one here, revenue shifts, as you probably saw in the tables that Sasha went through, and we can advance 2 slides actually. As you saw in those tables, we project that providers other than Mass General Brigham would be expected to lose between $153 and $261 million annually in commercial revenue as a result of just those aspects of the Mass General Brigham expansions that we were able to quantify. As I noted up top, because MGB tends to serve a more heavily commercially insured and generally wealthier population, this generally means that commercial revenue would be expected to flow out of systems that serve higher proportions of traditionally underserved patients, reducing the resources to care for those populations and potentially exacerbating health disparities. It's also important to note that as commercial revenue flows out of other provider systems, that also reflects market share, and that could widen price disparities. There's been a long-standing history of pretty extensive provider price variation in Massachusetts, and we and others have published reports on the degree of unwarranted provider price variation, and that could actually widen. It's also important to note that the expansions are particularly focused on high margin services, as I'll discuss in just a moment, but those are particularly important services to other providers, and so that too could exacerbate the effects. And then, of course, as Sasha teed up, to the extent that any of these changes destabilize other providers, that could exacerbate both the spending and access implications that we've highlighted. And it's important to note that many hospitals in Massachusetts have already seen substantial declines in commercial volume in recent years. So CHIA has a definition of what are called high public payer hospitals. In 2010, there were 39% of our community hospitals were considered high public payer hospitals, whereas in 2019, that number had gone up to 71% of community hospitals being high public payer hospitals. The next dynamic on the next slide is that, as I said, it's likely that the volume that would shift to MGB from other providers will be particularly focused on high margin services. So the ambulatory expansion applications and supplemental filings in particular provide relatively granular detail on advanced imaging and ambulatory surgery. Both of those services are generally identified as generating relatively high margin for providers per case. And of course, diagnostic imaging is also both a component of and a driver to follow-up care. So it can kind of keep you in the system. And of course, we're focusing a little bit here talking about the ambulatory sites, but it's important to note that advanced imaging is also one of the major pieces of the expansions at Mass General and Faulkner as well. In contrast to the level of detail provided on advanced imaging and ambulatory surgery, we note that whereas Mass General Brigham has stated that it will provide behavioral health services at the proposed ambulatory sites, and the HPC certainly recognizes the acute need for expanded behavioral health, Mass General Brigham has provided relatively few details on its plans for behavioral health services at these sites, which is traditionally a lower margin service. For example, it does not provide any information about the capacity or staffing expectations at these sites, or project behavioral health service volumes as it does for surgery and advanced imaging. And Mass General Brigham also emphasizes behavioral health integration, which of course we know has a lot of benefits. But at the same time, they also note that they will be strongly encouraging their behavioral health patients to have a Mass General Brigham primary care provider. And that approach could pose a barrier to patients seeking behavioral health services who have primary care providers with other systems.
Kate,
Yes.
sorry to interrupt. I just want to keep us moving so we can get to some conversation with the commissioners. So if you wouldn't mind just kind of hitting one bullet for each of these other dynamics, and then we can get to the conclusion and commentary. All of this detail is thoroughly articulated in our written comment.
Excellent. The next slide really just highlights unmet need. Here, it's important to note that Mass General Brigham and the ICAs really only look at utilization at specific Mass General Brigham facilities and line that up with demographic trends. They do not try to assess capacity at other providers. Other data does show that there is likely capacity elsewhere, and that was a large amount of testimony that was provided to the Determination of Need program. It's also worth noting that the ambulatory expansion sites are in areas that report having relatively good access to healthcare services, raising questions about whether they're necessary to meet unmet need. On the next slide, you see a highlight on payer mix. As discussed, Mass General Brigham acute care hospitals generally provide a lower proportion of care to mass health patients and a higher proportion of care to commercially insured patients, particularly because of the locations of the ambulatory expansions in what tend to be higher income areas with relatively few mass health patients. It's likely that those expansions will simply reinforce Mass General Brigham's payer mix that is already kind of weighted towards commercial volume. And finally, the last point here is on staffing. We note that Mass General Brigham will need substantial new staff for this new proposed capacity, which could really increase staffing costs for some providers, as well as lead to staff being recruited away from others, particularly providers with more limited financial resources, who may not be able to compete against some of the resources that Mass General Brigham has to recruit these providers. And of course, we are in a period of unprecedented instability in the Massachusetts healthcare labor market, which really isn't something that the applications seem to acknowledge and was not dealt with in depth in the ICAs. And I will pause here for questions and conversation.
All right, okay, phenomenal stuff. All right, questions or comments from my fellow commissioners? Okay, so overall conclusions? Yes.
I had a question,
Sure.
Stuart, it's Chris. You mentioned that there's several mentions of the independent cost analysis that was conducted and how its findings differ with our staff findings. I understood that it wasn't a fully independent cost analysis. Please confirm for me that it was a cost analysis that was paid for by MGB. Is that right?
Stuart, may I?
Yes, please.
So the statute, the current statute is clear that the Department of Public Health and its DON process, sorry, Don, I'm going to answer the technical question and then hand it back to you. I'm sorry about that. The DON statute allows the Department of Public Health to request an independent cost analysis paid for by the applicant. So that's one. And the second is the DON is limited, unlike HPC, is limited in the ICA process to each separate filing of the facility and cannot look at the system as a whole.
Yeah. So that's confirmation that the independent cost analysis was paid for by MGB.
All independent cost analysis would be paid for by the applicant. It's not just exclusive to MGB. Sorry, Don, didn't mean to, unless you wanted to take that question.
No, fine, you can interrupt me anytime.
No.
Secretary. Did you get your question? Should I go on?
Please, Don.
Okay, so I mean, first, just generally, one would not be surprised to find that the highest cost provider, large provider in the Commonwealth, when it expands at this level, would increase costs. We don't have a very surprising finding here, I guess. My question is about an earlier point. I think it was in Kate's part of the presentation. I can't remember. So in the application, they allege cost reduction as an effect, I guess, if I heard. But in other public comment, such as JP Morgan, they talk about increasing revenues and their overall revenues. So I guess the question I want to ask is, are they contradicting themselves? That is, does the DON's application say one thing and their public statements a different thing about their own estimates of the cost impact?
I'll jump in here. I would be cautious on characterizing contradiction here. The disclosures that we reviewed that were made public by the Attorney General's office speak to the larger ambulatory expansion projects and do state that they expect that they will generate additional revenue such to offset any losses of care that would be diverted out of the hospitals to those ambulatory sites. But as I think Kate and Sasha had mentioned, we don't have as much detail into that larger expansion plan and what that will, of course, entail. I think it's also probably worthwhile to differentiate between the total medical expense of MGB's patients and impacts on overall healthcare spending. So here, where if an MGB patient that would otherwise have received outpatient care at Mass General Hospital now would receive that same MRI scan at one of the MGB's ambulatory sites, that would be, reducing or cost savings for the MGB's TME. However, what the impact is on total healthcare spending may be quite different, as we would expect that the MGB will backfill, that capacity, draw patients in from other providers that are lower priced, and therefore increase overall healthcare spending. So to whom the savings accrue, I think is an important nuance to this. And our focus was really on what are the impacts to total healthcare spending in the Commonwealth, commercial spending in particular, as that will most closely relate to impacts on Massachusetts residents, employers, businesses that pay for commercial health insurance. So some nuance in kind of the interpretation there, Commissioner Berwick.
Thank you. Thank you, David.
Patty, why don't you go ahead? You
Patty,
muted.
you're
Muted.
Sorry. Was there any mention in the determination of need filed by MGB of their efforts to reach out to underserved communities? Because if you look at their mission statement, the last sentence is to improve the health and well-being of the diverse communities that we serve. So it would be nice if we saw that as a key component of this expansion, to make sure that they're fulfilling their mission statement and to see that they're outreaching into these communities that have been underserved. So I'm just curious.
Sasha, the applications. What was included here, and just on that point.
I think the most relevant item is that all DON applicants are required to go through a community engagement process prior to filing their applications, and MGB engaged in that process with local community groups, including some that I would think of as appearing to represent traditionally underserved populations. The exact impacts of those meetings on the planning process, I don't think that we have sufficient information to speak to.
Thank you.
Marty, sorry,
Yeah.
I lost the internet for a while. I don't know. Don, did you get to ask and get an answer to your question
Yes,
before?
thank you so much.
Okay, sorry. Marty, please.
Thanks, Stuart. Kate, Mass General has other facilities. I'm thinking Waltham. Do we know what the impact has been of those types of those facilities on cost?
So unfortunately, we have some data limitations that we don't have great before and after data, just based on the timing of their past ambulatory locations. So we can't really do the best analysis, which would be a robust kind of time trend, what happened before and after. What we can say is that we can look at the utilization rates in the communities, in particular around Waltham was one that we looked at. To test some of the assumptions that Mass General Brigham was making in the applications. And so one of the assumptions they made for the ambulatory sites is that all of the use of their hospitals by patients living near these sites would shift to the ambulatory sites. 100% of those patients would go back to the ambulatory sites. And we can look at what happened in Waltham. Do patients who use Mass General Brigham Imaging use the community site versus the hospitals. And we see that the majority are still using the hospitals. And so we don't think it's reasonable to expect that 100% of volume will shift from hospitals to the community. But unfortunately, we can't say big picture what the impact on spending has been.
Thanks.
Ron?
Yeah, basically, what I'm looking at is, in this particular case, what impact has there been on the marketplace in terms of the MGB type business and other hospital systems after the merger of Beth Israel and Leahy? Did MGB lose some market share? Also, it gets back to the point that Marty raised. When an operation like MGB goes into Waltham or goes into another city, right? I don't think an operation like Leahy, Beth Israel is just going to sit back. It'll be interesting to see how different organizations actually handled when MGB, when back then when Partners went into Waltham. How did the industry react? That's an interesting thing for us to look at. Because let's face it, they're looking to increase market share. So as any business would do, even though they're nonprofit, right? I'm learning a lot about nonprofits, right? They're trying to increase their business and they're trying to increase their market share. But how do the others compete? And we're looking at managing pricing. But I'll tell you, those other operations need to address that competitive factor as well. And what should we expect them to do?
So with regard to the first question on how market shares have changed after the merger of Beth Israel Leahy, it might actually be easiest to jump ahead. There are a number of the slides from our lengthy comment in the appendix to this deck. So I believe slide 77 shows some market share figures. So thank you very much. So this is from fiscal year 2019. So it's worth noting that because of the recent merger of Beth Israel Leahy, we really don't have much data kind of post-merger. And what data we do have, what data we will have then will also be complicated by the pandemic. So it may take a little bit of time to see exactly how it all plays out. But the major change that has happened wasn't that Mass General Brigham's share kind of overall changed. It was that the second and third largest, or in some cases, second and fourth largest, their shares got combined. So if you look to the share of outpatient discharge equivalents, you'll see that Mass General Brigham has an 18% share of kind of outpatient volume, whereas Beth Israel Leahy has a 22% share. So Mass General Brigham is no longer number one for outpatient volume. It is number one for inpatient volume, inpatient revenue, and notably for outpatient revenue. So that the NPSR is net patient service revenue because of the pricing differential. And so even though they have less volume, because their prices are higher, they have more of the revenue. And so based on what we've seen, we haven't seen some major change in Mass General Brigham's market share relative to other providers. What we have seen is that Beth Israel Leahy's share has changed. So that's on the first point. And then on the second point with regard to provider responses, you're absolutely right that other providers will respond. And so one of the things that is a little tricky here is that Mass General Brigham has so many resources that they are going to be better able to compete in certain ways than other providers in the market. But it may very well be that if there are patients, for example, who shift from Beth Israel Leahy to Mass General Brigham as a result of an expansion, that Beth Israel Leahy may be better able to kind of backfill its own patients. And what you might actually get is a much bigger backfill effect than what we were able to model. So we modeled what would happen if Mass General Brigham shifted some of its patients to the ambulatory sites, shifted from some of its AMCs to Faulkner, and then backfilled that volume at its hospitals at its AMCs. But what we didn't do is the next layer of, and then if some of those providers backfilled volume, because generally it's going to be the more resource providers who are best able to backfill, those also tend to be the providers with the higher prices. It may very well be that once you start doing this backfill all the way out, that any savings get negated by kind of a bigger backfill effect.
Good points, Kate. Good
Thank-
points.
Just quickly on this point, I'll look to you, Sasha. Did in comments that competitors submitted to DON, did they state what they would do?
Competitors, I don't believe, have spoken strongly to that point, apart from saying that the loss of business to MGB would impact their operations.
Thank you.
And noting throughout a lot of the provider testimony that, many of the providers say that they have capacity and that they could provide these services.
Let's move back to the conclusion slide, please.
Yes.
Stuart, if I could ask one more question.
Sure, Don.
Yeah, I'm sorry, I don't want to belabor this. I just want to probe a little more on the completeness of the information we have and the good faith of the applicant in providing everything. We did have to turn to materials accumulated by the Attorney General that were not in the original DON application, as I understand this. Is there anything else that we wish we knew that would help further understand this that we cannot get access to? Or are you satisfied that the information that we finally do have give us as complete picture as we want to estimate the cost impact?
I will take a shot at this. I would say there is probably always a desire for more information, for more detail, for more data, for more background information. And, in so doing, aids in these types of very robust analyses. I'll just say as a blanket statement, we feel confident that we had sufficient data to stand behind this comment and the conclusions therein. And so I will leave it at that.
All right, so David has put up the conclusions. So why don't you just pull it all together? Or Kate or David?
Well, thank you. Yeah. So in conclusion, we estimate that these proposals are likely to drive new patient volume to the higher cost MGB system, particularly commercially insured volume, resulting in an increased spending, increased commercial premiums, and negative impacts on market functioning. We estimate and quantify of the drivers that we were able to have data and information for, $46 to $90 million in annual commercial spending increase broken down by these three projects. In addition, we see likely shifts of substantial commercial revenue to the MGB system and away from other providers in the Commonwealth. And given these impacts, the conclusion of our letter and comment is that the projects are not consistent with the Commonwealth's goals for cost containment. And so the question to the board is to approve the submission, the issuance of this comment to DPH and the determination of need program.
Before we vote on the motion, I just want to make clear that the ultimate responsibility for the determination of need rests within the department. Our job, and I think it was done amazingly well, was to analyze the proposed changes on whether they would impact on the benchmark spending, on the availability of resources, on the extent to which the proposed change would have an impact on availability of services, particularly for lower income communities and marginal communities. And as you see in the conclusion, our strong assessment is that how we looked at this would substantially increase in spending and have a clear indication of reducing revenues to those institutions who we count on to provide services to these lower income and marginalized communities. And our role is to then, if we agree, to turn over this report and these conclusions to the department for their final decision-making process. And so that's what this motion is all about.
Stuart,
Yes, Chris.
yeah, just one comment or a question, really. Do we have the ability in our motion to separate the proposed investments? I mean, my own view is that you're building a new tower on Fruit Street and investing in the Faulkner. That seems fine for a giant hospital company. But I feel differently about the ambulatory centers. Is there a way for us to thread the needle a little here?
Let me be very clear, Chris. Our recommendation does not go to the issue of whether any one part or the total should go forward or not. It would be inappropriate for us to make any comments about whether this part is appropriate and the other isn't appropriate. Our role here was to do a systematic analysis of the spending potentials of these in combination and separately. So that's why I made the statement that I did. The decision on whether all of it, some of it, some portion of some of it should be approved or not approved is not within our purview. That is the department's decision. And therefore it would be inappropriate for us to make a comment about our own personal views of whether this part should go forward or not.
So Stuart, may I?
Please.
So when the Department of Public Health posted the independent cost analysis in December, it then creates a 30-day window for parties of record to comment. And that is what the Health Policy Commission, and as I think you heard from David, Kate, and Sasha, conducted not just an analysis of the ICA, but then additional information that is then submitted as a party of record, assuming that's the vote that the board takes, submits this as a party of record to the Department of Public Health as it then goes through its determination of need process of the three filings. So it's not opining on the benefit, HPC is not opining about the benefits of any particular DON filing, but as a party of record, providing the cost analysis and other factors that the Department of Public Health should take into consideration in the main, in the total. So I think that's I don't know if that helps, Chris, in this, the distinct roles of the Attorney General, the Health Policy Commission, and the Department of Public Health.
Yeah, yeah.
Interpretation.
Yeah, no, that does help, but it is, I think a legitimate question, since our mission is to advance a more accountable system. It's a complicated proposition, right? And acute care is very different than ambulatory care. But I understand, and I will leave it alone.
Okay, so thank you, Chris. And are there any other final questions or comments? If not, there is a motion that is on the screen. So do I have anybody pushing that motion?
Stuart, I'll move the motion.
That's right. Is there a second?
Second.
Second.
Very good. Colleen, I will ask you to do the bidding and do this by voice vote.
Absolutely. We are voting to authorize the issuance of the HPC's public comment, and I will start with you, Mr. Chairman.
I approve of the issuance of the report.
Thank you. Vice Chair Cohen,
Aye.
Commissioner Berwick,
I approve.
Commissioner Blakeney,
Aye.
Commissioner Foley.
Issuance of the report?
Yes. Thank you. Commissioner Haupt,
Approve.
Commissioner Kreider,
Approved.
Commissioner Master Giovanni.
Aye.
Thank you. Secretary Sutters. Thank you. And Commissioner Roeder.
Approve.
Thank you.
Well, again, I want to thank the staff. I have read and reviewed in detail this report several times. And the level of detail and commitment that the staff went through is really incredible. So I want to thank you, David, for the amount of work that you and the staff have put into this effort. And I want to thank my fellow commissioners for the careful review that you went through in doing it. This is an important report. And with that, I'm going to turn the program back to you, David, to make some final comments.
Well, thank you, Commissioner, and likewise, thank you, all commissioners, for your support, guidance, feedback, insight, prodding along the way on both of these important reviews that we covered today. So I will just wrap up today's meeting with just a very brief executive director's report. Just noting that we had quite a successful 2021. Here we just summarized some of the major data points from the year. We like to do this by the numbers. We love data at the HPC. And so just a really tremendous and successful 2021, even in our continued virtual remote working environment. We issued many different new publications. We continued to make important investments into community-based care to address social determinants of health. We held 20 public meetings on Zoom, which is incredible, almost 1,000 slides presented through the year, and continue to have a steady flow of market transactions that we reviewed, and patients and residents of the Commonwealth that we assisted along the way. On the next slide, excuse me, just one second. So just want to give the regular update on our MCN tracker. So this is our regular slide of noticing how many transactions we've noticed. On the next slide, wanted to note that since our last board meeting, the HPC elected not to proceed to a cost and market impact review on one provider transaction. This was the joint venture between Bay State Medical Center and NEOS SurgCo, which is a group of approximately 18 BayCare affiliated orthopedic surgeons. Under the proposed transaction, the parties would acquire ownership of Bay State Orthopedic Surgery Center, an existing Bay State Hospital outpatient ambulatory surgery facility in Springfield, and as part of the joint venture, operated as a freestanding ambulatory surgery center. In our preliminary examination, we found limited scope for spending or market impacts due to this transaction, and there is actually a potential for spending decreases as surgical procedures at the ASC shift from the hospital-based facility rates to the freestanding ASC facility rates. We did not review any evidence that will impact negatively quality or access. On the next slide, you can see that we currently have a large number of transactions under review. I would note that it's been a particularly busy time in our healthcare marketplace. So we have a proposed joint venture between a subsidiary of Beth Israel Deaconess Hospital Plymouth and Pilgrim Ambulatory Surgery Center to own and operate a freestanding ASC in Plymouth, a proposed clinical affiliation between Atrius and South Shore, a proposed transaction under which Shire Orthopedic Partners would acquire certain non-clinical assets of Sports Medicine North Orthopedic Surgery, which is a physician group on the North Shore, a proposed transaction between Signature Healthcare, South Shore Health Sturdy, and a subsidiary of US Health Vest to own and operate a new psychiatric hospital in southeastern Massachusetts. And finally, a proposed joint venture involving New England Baptist, its orthopedic surgeons on its staff, and a surgery center management company that aims to own and operate a freestanding ambulatory surgery center in Dedham. So we are under review of all of these transactions, and we'll be in touch as we have findings on their potential impacts in the weeks to come. And finally, just wanted to note that we have a couple of new materials up on our website. We issued a chart pack on certified nurse midwives and maternity care in Massachusetts. And as part of the rollout of this new report, we also issued what we call HPC Shorts, which is a short YouTube video, 2 to 3 minutes, that highlights some of our findings using animated graphics. So highly encourage you to check those out. Those are really, really nicely done and really engaging with the data. And next slide is our public calendar for 2022. So commissioners, we will be back with you together on February 9th. So just in a short time from now for committee meetings with the MOAT committee and the Care Delivery and Transformation Committee meeting starting in the morning on February 9th. So that will be our next public meetings on our calendar. As always, we may have to add more meetings as the year progresses to deal with timely issues. And I think that ultimately concludes our agenda for today. Again, thank you, commissioners, and we look forward to continuing this work together in 2022. I'm happy to answer any questions on everything I just ran through pretty quickly.
Great
Otherwise,
job, HPC's team. Great job.
Yeah. Yes, let me echo that, David. Again, a lot of very important issues were discussed today. And again, I want to thank you and the staff for all the work you've done. Is there any final comments any of my fellow commissioners would like to make? If not, I will accept a motion to adjourn. Having listened to everyone saying adjourn,